Imagine trying to cure a chronic, like really agonizing intimate health condition using highly purified DNA extracted from a salmon trout.
Right. It sounds completely insane.
Yeah, I mean, like something out of a bizarre science fiction novel. But looking at your stack of sources today, the ones you sent in for us, it might actually be the absolute cutting-edge future of women's medicine. Welcome to the Deep Dive.
Glad to be here.
Today, we are taking the materials you sent us, this massive stack of clinical trials, real-world case series, and specialized clinic FAQs, and we are looking closely at a silent epidemic affecting literally millions of women.
Millions! It's staggering.
We are talking about severe intimate health conditions, specifically vulvovaginal atrophy, or VVA, and lichen sclerosus.
And the goal today is to really give you, the listener, the knowledge to understand the actual cellular science behind these conditions.
Right.
We are moving beyond the surface level symptom management that has dominated this field for decades to look at the breakthroughs happening right now in regenerative medicine, like how to fundamentally rebuild damaged tissue from the inside out.
Okay, let's unpack this, because usually when we talk about a medical diagnosis, there's this expectation of like mechanical precision. You have a headache, you take a pill, the headache goes away.
Exactly, a simple one-to-one fix.
But then you step into the world of intimate women's health, and that simple model just completely falls apart.
Right.
We are looking at a diagnostic and therapeutic landscape that is historically overlooked and, frankly, incredibly complex.
Very much so.
So before we can understand how regenerative medicine rebuilding works, especially that salmon DNA part, which I am very eager to get to, we need to understand exactly what is breaking down in the body and why.
Well, we need to clearly differentiate between the two major conditions highlighted in your sources because their underlying causes dictate entirely different treatment approaches.
Okay, lay it out for us.
Let's start with genitourinary syndrome of menopause, or GSM, and its core component, which is vulvovaginal atrophy, or VVA. This condition is fundamentally driven by a systemic loss of hormones.
The estrogen dropping.
Right. During menopause, a woman's estrogen levels drop precipitously. We're talking about falling from premenopausal peaks of around 800 picograms per milliliter down to below 30.
Wait, below 30? That is a massive physiological cliff to fall off.
It's a total systemic shock because, estrogen isn't just a reproductive hormone. It is a crucial signaling molecule that maintains the health, the thickness, and the elasticity of the vaginal epithelium.
So it's basically telling the tissue how to stay healthy.
Exactly. When you remove that estrogen signal, the tissue literally stops maintaining itself. Clinically, you see loss of elasticity, which presents as a flattening of the vaginal rugae.
Oh, I saw that term in the papers. Rugae. Those are essentially the natural, healthy folds or pleats in the tissue that allow it to stretch.
Yeah, correct. When those folds flatten out, the tissue becomes really rigid and fragile, and concurrently, the local microbiome changes.
The bacteria.
Yeah, the healthy lactobacilli bacteria diminish because they rely on glycogen produced by estrogen-stimulated cells. Without lactobacilli producing lactic acid, the intravaginal pH rises, creating an environment that's far more susceptible to infection and irritation.
So the structural breakdown leads to a cascade of awful symptoms. The clinical data details severe vaginal dryness, burning, itching, and severe dyspareunia, which is the medical term for pain during intercourse.
Right. It's debilitating.
But then, right alongside VVA in the literature, we have vulvar lichen sclerosus, or VLS. And reading through this, VLS feels like a totally different beast.
Oh, it is entirely different in its pathology. Unlike VVA, which is hormonally driven and a consequence of aging or medically induced menopause, VLS is a chronic autoimmune inflammatory skin disease.
So the body's attacking itself.
Yes, it primarily affects the anogenital region. With VLS, the body's immune system is actively attacking its own tissue. This results in intense itching, severe scarring, and a literal loss of vulvar architecture.
Wait, loss of architecture. What does that actually mean for the patient?
Well, it means the chronic inflammation is so severe that the labia can fuse together and the clitoris can become buried under scar tissue.
Oh.
Yeah, the physical structure of the anatomy is distorted or destroyed. Furthermore, because of the constant cellular turnover and chronic inflammation, VLS carries a very real 4 to 6% risk of malignant transformation.
Like turning into cancer.
Yes, specifically squamous cell carcinoma, a type of skin cancer.
Okay, so if I'm picturing this, VVA is like a garden that is slowly drying up and withering because the water source, the estrogen was just turned off.
That's a good way to look at it.
But VLS is like that same garden being actively attacked by a systemic weed, an autoimmune weed that strangles the plants, fuses the soil, and leaves a dense network of thick, distorted scar tissue behind.
That analogy captures the distinct mechanisms perfectly. And what's fascinating here is how these different physical breakdowns translate to sheer psychological weight.
Right, the mental toll.
If we connect this to the bigger picture, the emotional burden of both these conditions is immense. Your sources mention the VVA survey, which looked at over 3,500 postmenopausal women across multiple countries.
And the numbers were staggering.
75% of symptomatic women reported dire consequences on their daily lives, their self-esteem, and their intimate relationships.
And the sources specifically highlighted how medicine tries to measure that suffering. There was this cross-sectional study comparing standard quality of life indexes against a tool called PRISM, which stands for Pictorial Representation of Illness and Self-Measure.
I love that study. The PRISM tool is a brilliant approach to capturing subjective suffering. Instead of just, answering a sterile multiple-choice questionnaire, the patient is given a blank surface representing their life and a physical disc representing their disease.
So they literally map it out.
Exactly. They are asked to place the disc on the board to visually represent how much space the disease takes up in their life. It proved to be highly sensitive.
I bet.
It captured the true devastating burden of patient distress far better than standard questionnaires. It proved visually that these conditions are deeply disruptive to a woman's fundamental sense of self.
So, if this disease is actively fusing tissue and destroying a woman's psychological well-being, standard over-the-counter moisturizers are like bringing a water pistol to a house fire.
They do absolutely nothing to stop the disease progression.
Right. Medicine has to go on the offensive here.
Yeah.
How do we currently put out the fire, especially for the autoimmune attack of VLS?
For vulvar lichen sclerosis, the absolute gold standard of care is the application of ultra-potent topical corticosteroids. Specifically, clobetasol propionate 0.05% ointment.
Okay, the heavy-duty steroids.
Yes. The standard induction protocol is a daily application for about 12 weeks, followed by a long-term tapered maintenance phase.
And how does that work exactly?
The mechanism here is essentially blunt force immunosuppression. The steroid permeates the cells and actively turns off the inflammatory pathways. It halts the immune attack, stops further scarring, and reduces that risk of cancer.
Okay, I have to push back here for a second. If clobetasol is the absolute gold standard and it works by turning off the immune attack, why are there so many trials in our sources testing a whole arsenal of alternative therapies?
That is the big question.
Yeah, because I was reading about fractionated CO2 lasers, NYAG lasers, platelet-rich plasma injections, lipofilling, even photodynamic therapy. If the steroid cream is the gold standard, clearly it's failing in some way.
You've zeroed in on the exact limitation of our current medical paradigm. Clobetasol is excellent at putting out the inflammatory fire, but complete clinical clearance of VLS is infrequent.
So it manages it, but doesn't cure it.
Right. One of the observational studies in your stack noted that a patient's quality of life only drastically improves if they achieve complete clearance, what they call a global subjective score and global objective score of 0.
A perfect 0.
Yes. If a patient achieves even a 90% improvement, but still has lingering symptoms or structural damage, their psychological distress remains remarkably high. Mostly better simply isn't good enough when it comes to intimate pain.
Plus, I have to imagine rubbing an ultra-potent steroid on delicate tissue every single week for the rest of your life has to have consequences. Doesn't long-term steroid use cause the tissue to thin out even more?
It does. It can lead to severe mucosal atrophy. That's why science is desperately searching for alternative or adjunct therapies. But let's look at the mechanisms of those alternatives you mentioned, because they illustrate how hard it is to actually heal this tissue.
Right, the lasers and stuff.
Take fractionated CO2 lasers, for instance. They work by firing microscopic columns of thermal energy into the tissue, creating thousands of tiny, controlled wounds.
The idea being that you injure the tissue to force the body's natural healing response to kick in and build new collagen.
Precisely. Platelet-rich plasma, or PRP, involves drawing the patient's blood, spinning it down to isolate the platelets, and injecting them back in to release growth factors.
Okay.
Lipofilling involves taking fat from a patient's thigh or abdomen, isolating the stromal vascular fraction, which is a layer rich in adipose-derived stem cells, and grafting it into the vulvar tissue.
Wow, that's intense.
And photodynamic therapy applies a photosensitizing gel, called 5-ALA, then exposes it to a halogenic lamp. The light reacts with the gel to create singlet oxygen, which selectively destroys the damaged cells.
That all sounds incredibly invasive. We are burning tissue with lasers, grafting fat, and using glowing gels to destroy cells.
Mm.
It sounds like all of these therapies are trying to force a heavily damaged, exhausted tissue to magically heal itself.
And that is exactly why they often fall short. They rely on an inflammatory healing cascade in a tissue environment that is already structurally compromised or actively inflamed.
Right, the soil's already ruined.
Exactly. Medical researchers realized they needed a way to provide the actual building blocks for repair without relying entirely on the body's depleted resources.
Which brings us to the absolute wildest part of your sources, the regenerative frontier.
Yes, this is where it gets really innovative.
Right, because once the autoimmune fire of VLS is controlled, or in the case of VVA where the issue is purely a structural breakdown from a lack of estrogen, we need to rebuild the house. And here's where it gets really interesting. We are talking about polynucleotides, specifically PNHPT.
The salmon DNA.
Yes, and I need you to explain this to me like I'm 5, because the source material states we are using highly purified DNA from the gonads of male salmon trout. Are we actually injecting fish DNA into human tissue?
We are.
But why does the human body just immediately reject it as an invader? What about severe allergic reactions?
It sounds alarming at first glance, I know, but it is deeply rooted in elegant biochemistry, and it is incredibly safe. The polynucleotides used in these specific medical devices are strictly governed by USP and European pharmacopoeia quality standards.
Okay, so it's highly regulated.
Very. The extraction process involves advanced thermal sterilization at very high temperatures, followed by intense deproteinization.
Deproteinization, meaning they strip away every single protein from the salmon material.
Yes, every last one. Allergies and severe immune reactions are almost exclusively triggered by proteins the body recognizes foreign proteins and attacks.
Oh, that makes sense.
By completely eliminating the immunogenic proteins and leaving only the pure long-chain DNA polymers, the resulting gel is highly biocompatible. Human DNA and salmon DNA at this fundamental structural level are made of the exact same basic building blocks.
The ACTG base pairs.
Exactly. The immune system doesn't recognize it as a foreign fish protein. It recognizes it as natural biological material.
Okay, so the immune system leaves it alone. But how does rubbing or injecting this purified fish DNA actually fix vaginal atrophy?
It works through a brilliant mechanism called the enzymatic salvage pathway.
Salvage pathway.
Right. When these long, three-dimensional polynucleotide chains are introduced into the dermis, native tissue enzymes, specifically deoxyribonucleases, or DNases, recognize them. These enzymes begin to slowly cleave or chop up the long polymer chains.
Okay.
This progressive breakdown steadily releases small nitrogen precursors, like nucleosides, nucleotides, and free nitrogen bases, directly into the extracellular matrix.
So it's acting as a, slow-release fertilizer for the local cells. You put down this gel, and the body's own enzymes slowly break it down into raw cellular food.
That is a phenomenal analogy. Those fertilizer molecules then bind to specific receptors on the surface of local cells, most notably the CD44 receptors on fibroblasts.
And fibroblasts are essentially the microscopic factories in our tissue that manufacture the structural scaffolding, right?
Exactly. When a fibroblast CD44 receptor is activated by these nucleosides, it stimulates the cell to proliferate and dramatically ramp up its metabolic activity.
It wakes them up.
Yes. The fibroblasts start churning out endogenous collagen type I and type 3, which provides tensile strength as well as new elastin for flexibility and glycosaminoglycans for hydration. You are literally feeding the cellular factors the exact raw materials and signals they need to rebuild the mucosal structure.
It's signaling the body's own cellular machinery to turn back the clock and rebuild the garden. I love that. I also noticed this source is highlighting something about free radicals and hydration. How does the DNA gel physically protect the tissue while it heals?
The three-dimensional macromolecular structure of the polynucleotide gel naturally traps and scavenges free hydroxyl radicals.
Which are bad, right?
Yes, hydroxyl radicals are highly reactive molecules that cause oxidative stress and damage cellular DNA. So while the polynucleotides are signaling the fibroblasts to build new tissue, the gel structure itself is acting as a chemical shield, protecting those vulnerable mucosal cells.
That's incredibly multifunctional.
And furthermore, the gel is highly hydrophilic, meaning it binds strongly to water molecules, providing immediate, profound physical hydration to the dry mucosa.
The underlying biochemistry is just fascinating, but how does this translate from the lab to an actual patient in a clinic? Let's talk real-world protocols. For vulvovaginal atrophy, The sources highlight a specific clinical approach called the Nugent or Plinus protocol. Walk us through the actual mechanics of this treatment.
Sure. This specific protocol relies on the synergistic effect of both polynucleotides and hyaluronic acid. It typically begins with 3 priming sessions.
Okay, priming.
After applying a topical lidocaine cream for comfort, the clinician uses a very fine needle to inject a highly concentrated polynucleotide gel, usually 40 milligrams in a 2 milliliter syringe, directly into the dermis of vulvar skin in the deep mucosal layer called the lamina propria.
The lamina propria being the structural foundation underneath the surface skin.
Yes. These 3 priming sessions are spaced about 2 to 3 weeks apart. The goal here is purely regenerative. The polynucleotides activate the fibroblasts and lay down the new collagen and elastin matrix.
Building the scaffolding.
Right. And once that foundation is primed, it is followed by 2 consolidation sessions using high molecular weight hyaluronic acid.
Why switch to hyaluronic acid at the end? Why not just keep using the DNA?
Because hyaluronic acid is nature's ultimate sponge. It delivers massive deep hydration and supports the newly active fibroblasts, restoring the physical turgor, the plumpness and elasticity of the mucosa.
And looking at the data from the prospective cohort studies, the results are wildly impressive. Instead of throwing a bunch of decimals at you, here's the quick version. Within just 3 months of this protocol, over 3/4 of the patients saw their most maddening symptom, the itching, virtually disappear.
That's huge for quality of life.
Yeah, and the soreness and tingling dropped by 70%.
Yeah.
And the dyspareunia, the pain during intimacy, was cut in half. And for women who absolutely do not want injectables, there was a real-world study on a non-invasive version, daily vaginal ovules that combine polynucleotides and hyaluronic acid.
I saw that one.
In that study, researchers saw vaginal hydration boost by nearly 60%, with a significant restoration of a healthy, acidic pH.
The clinical efficacy for VVA is thoroughly documented and highly encouraging. However, this raises an important question, and we must address a critical boundary in the treatment landscape, specifically regarding lichen sclerosus.
Right, because they aren't the same.
Exactly. We need to look closely at the caveat detailed in the clinical FAQ from the Women's Health Clinic.
Right, because earlier we established that VVA is a structural breakdown from hormone loss, but VLS is an active, aggressive autoimmune fire.
Yes. The clinical sources strictly advise that polynucleotides should not be positioned as a primary treatment for advanced or active lichen sclerosus. You cannot use regenerative medicine on actively inflamed tissue.
It just won't work.
No, inflammation, hyperkeratosis, and nerve density issues require diagnosis-led care first.
Okay, let me make sure I'm translating this correctly. You can't use these raw building materials, the slow-release DNA fertilizer, while the garden is still actively on fire from the autoimmune attack. The immune system will just destroy the new tissue as fast as you build it.
Exactly.
You have to let the ultra-potent clobetasol steroids put out the fire first. You achieve disease control, and then, only then, can you bring in the polynucleotides as an adjunct therapy to help rebuild the scarred, damaged structure.
That is the precise clinical consensus. Promising to reverse active VLS with regenerative injections alone is fundamentally flawed. However, as an adjunct therapy used alongside the steroids once the severe inflammation is managed, the data shows remarkable promise.
Yeah, that makes perfect sense.
For example, your sources include a clinical study on male genital lichen sclerosus.
Oh, I saw that. The PDRN study. PDRN stands for polydeoxyribonucleotide, which is essentially just a slightly lower molecular weight version of the salmon DNA polymers we've been talking about, right?
That's correct. In this specific study, patients were divided into 2 distinct groups. One group used only the gold standard clobetasol propionate steroid cream. The second group used the steroid cream combined with subdermal PDRN injections directly into the fibrotic lesions.
And the results really highlight why combining the firefighters with the builders is the future.
They do. The group receiving the combined therapy experienced significantly better clinical improvement, a measurably greater reduction in pathological scarring, and a significantly higher quality of life score than those using the steroid alone.
That's incredible.
It objectively proves that suppressing the immune system is necessary, but adding a specific regenerative signal to heal the scarred tissue yields a vastly superior clinical outcome.
So what does this all mean for you, the listener? It means we are witnessing a fundamental paradigm shift in intimate women's health. For decades, women have been told that intimacy pain, severe dryness, and tissue degradation are just inevitable parts of aging, or something they simply have to suffer through with a chronic autoimmune illness.
Right, just told to manage expectations.
But the science says otherwise. Medicine is moving from merely masking symptoms or handing out standard moisturizers, to genuinely restoring mucosal elasticity and cellular health at the DNA level. We aren't just managing the decay, we are teaching the tissue how to act young and healthy again.
And that leaves us with a profound concept to consider. Polynucleotides work by essentially hacking the body's own enzymatic salvage pathways.
Right, chopping up the DNA.
They provide the exact recycled DNA fragments required to trigger rapid cellular repair and collagen synthesis. If highly purified salmon-derived DNA can successfully signal our most delicate, intimate tissues to rebuild themselves from the inside out simply by turning on these dormant cellular receptors, what other dormant regenerative pathways exist in our bodies, just waiting for the right molecular key to be turned on?
Man, it really makes you rethink this simple mechanical model of medicine we started this whole conversation with, doesn't it?
It definitely changes the perspective.
The body isn't just a machine with permanently broken parts. It's a complex, living ecosystem just waiting for the right signals to heal itself. Thank you so much for joining us on this deep dive into your sources. Until next time, keep questioning, keep learning, and keep diving deep.